Great. I am just going to get started because the beginning is just a little bit of intro anyway. First of all, I want to thank everyone for coming. I know it's a very long day of talks. This is also a talk, but it is meant to be interactive. We don't have a moderator, and I will be just presenting the slides, but kind of stopping for questions. If you have a question that feels super urgent, you can just unmute, because it is like a Zoom meeting. You can just unmute and ask it. And if I'm getting to it, I'll tell you I'm getting to it. But if it seems appropriate to answer at that moment, then that's what we'll do. The other thing I wanted to say is that actually my Wi-Fi is pretty good, but it does occasionally cut out, and we do have a storm, as I'm sure you've heard. So if you feel like my Wi-Fi is cutting out, tell me, and I will go off video, because that does help the Wi-Fi, of course, but I prefer to be on video otherwise. Okay, so let me just stop and see how many people are here. Okay, we have 25 people. I think that's enough to get started. So let me share again. Great. Okay, so today what we're gonna, I want to disclose that I do serve on 2 data monitoring committees for Novo Nordisk. I'm not going to be discussing, I don't think, any Novo Nordisk specific products today. So what I want to cover today in this talk is the physiology of hypoglycemia, sort of the clinically relevant physiology and what to kind of keep in mind when you're evaluating a person with hypoglycemia. And then I'm going to talk about hypoglycemia and diabetes, because that, of course, is the common scenario in which we see hypoglycemia, and it can be challenging to manage even in the age of CGM. I have one sort of illustrative case. And then I have a bunch of mini cases that touch on all the kind of differential diagnosis of hypoglycemia, but it doesn't cover anything. So if you have a particularly challenging case of hypoglycemia or a question, we will have time at the end. And I do have one person already on the call who I think is planning to share a challenging case of hypoglycemia. Would be happy to discuss if you have others as well. So just to go over, so we're all on the same page, the physiology of hypoglycemia. Normal physiology, we eat our little glucose molecules in whatever form we prefer them. They hit the stomach, and we know we have all these little gut peptides that get released from the pancreas. But of course, the very first thing that happens is insulin will rise and decrease free fatty acid production, decrease lipolysis, and help to stay the Can people hear me? Can you go on mute if you're not speaking? And I'm assuming, can people hear me? Yes? Thumbs up? Okay, good. Very good. So let me come back here. So insulin will rise, glucagon will fall. There'll be suppression of lipolysis, suppression of free fatty acids, and the insulin will act on the liver to suppress gluconeogenesis, of course, and help store glucose as glycogen. And then, of course, insulin will go and act on the muscle and the brain to drive glucose into muscle cells and go through GLUT4 transporters to sort of drive glucose into cells and lead to an anabolic effect. That's the net effect. The normal response to hypoglycemia, nothing's coming into the stomach. What happens? Well, glucagon rises, insulin falls. It doesn't disappear. When insulin disappears completely, we have unregulated lipolysis, and we end up in DKA. But we don't, in the normal state, have a total absence of insulin. We have an increase in the glucagon to insulin ratio, and that glucagon acts on the liver to increase gluconeogenesis. It acts on the fat to lead to free fatty acid release. That's a feed-forward process where epinephrine in the fasting state or in another kind of stressed state will also act on hormone-sensitive lipase to promote free fatty acid release. And that, of course, is what keeps us from passing out when we're fasting and helps fuel us when we're kind of running from our tiger or in a starving state. We start to metabolize our own tissues. And that is all well and good. And we'll keep that in mind as we go through the talk. Okay, I want to talk about the approach to hypoglycemia. The very most important part of evaluating a new complaint of hypoglycemia in the absence of diabetes is to get a very good history. A very good history. And that history must include assessment of Whipple's triad, and you need to be satisfied that all conditions are met. So the patient needs to be symptomatic. Obviously, there's adrenergic symptoms of hypoglycemia, sweaty, shaky. Those are the ones that come from epinephrine as our blood sugar falls. And people will feel terrible. They feel sweaty, they feel shaky, palpitations. And after those symptoms happen, and we'll talk more about this, People, of course, have neuroglycopenic symptoms. So the person with diabetes, type 1 diabetes, who's taken too much insulin, has a lot of hypoglycemia, has lost that adrenergic response, and we're going to come to why that happens. They don't get shaky, sweaty. They don't get palpitations. They get confusion. They get kind of being a little loopy. They get coma, seizure, and ultimately death from neuroglycopenic symptoms. The reason this history is so important, as we're going to come to when we get into the cases, but I just really want to hammer this point home while people are still on the call. Bad hypoglycemia causes neuroglycopenic symptoms. And this is, so it's a super important part of kind of sussing out the history. What are people's symptoms of hypoglycemia? Then what is the actual glucose at the time of the symptoms? Because of course, people can get symptoms of confusion with a totally normal glucose due to things like a seizure or other kinds of causes of confusion, mini strokes, TIAs, what have you, but commonly, you know, a seizure. So they really need to have a documented low glucose, and I mean really low. Glucometers can overcall hypoglycemia, so can CGMs. You know, you want really low in the 50s or below to really feel like this is serious or severe hypoglycemia in the absence of diabetes. And then there needs to be rapid resolution after correction of hypoglycemia. So you give a rapid acting carb and really within minutes, you know, people feel better. It's not 3 hours later, I'm finally feeling better. That would suggest more of a post-ictal state or something else, not correction of hypoglycemia. Somebody asked, will we get the slides? I thought you had the slides, but yeah, Jenny can absolutely, not Jenny, I'm sorry, Melly can definitely give you the slides as a reference, no problem. Okay, in terms of the differential diagnosis of hypoglycemia, so first you need the history, and the history not only should have, I should just take a step back, not only Whipple's triad, it should really have, you know, what are the triggers? When do you have it? Is it fasting? Is it postprandial? What did you eat beforehand? Was there activity? Had you been fasting for several days? You know, all of these kinds of things, you know, that really lead you to kind of hone in on what is actually going on in hypoglycemia. But a very important point is this patient sick or is this patient healthy? Because we are called a lot for hypoglycemia in patients who are sick and where the cause is often not the rare fascinoma, but sort of the perfect storm of many factors, all kind of combining to cause hypoglycemia. So you have a patient in the hospital with chronic kidney disease, where the kidney is responsible for about 10% of gluconeogenesis, but they really have a lot of fasting hypoglycemia, plus they're malnourished, plus they've been kept NPO for a couple of days, and lo and behold, every morning on that, you know, basic metabolic profile, their glucose is like, you know, 58, and glucose has even fallen in the tube, and the team calls you and says, I'm worried about an insulinoma. No, that is not an insulinoma. That is a sick patient with chronic kidney disease. Similarly, people with hypopituitarism or adrenal insufficiency. I know there's a pediatrician on the call. It's very rare that adrenal insufficiency presents with hypoglycemia in a healthy adult, but in a sick adult who's under-replaced with their steroids, either from primary or secondary adrenal insufficiency, absolutely. A sick adult who is malnourished, NPO, can absolutely get hypoglycemic from adrenal insufficiency. There's other endocrine causes like post-FEO resection, liver failure only when it's very severe, sepsis, obviously a common cause. IGF-2 producing tumors are not a cult. These are big tumors usually, and you can usually find them, but you know, we do occasionally worry about those, so something to keep in mind. The IGF-2 cross-reacts with the insulin receptor, starvation, malnutrition, and then there's genetic causes. So if you have a sick patient, it's really one differential diagnosis. In the apparently healthy patient, the patient who walks into your office with a diagnosis of hypoglycemia, this is a very challenging thing. As an endocrinologist, it makes you anxious because you don't want to miss a terrible thing. But in the apparently healthy patient, you really want to think what's going on here. First of all, is an artifact. As I just said, that glucose sits around in the tube. It can often fall in the tube, so you just want to recheck it, particularly if the patient was asymptomatic. Medications, which include alcohol, purposeful or accidental ingestion of glucose-lowering medications. We had a case that someone used to present at this course many years ago of a patient who was taking what he thought was one medicine, but actually had been dispensed glyburide erroneously by the pharmacy, or people can sometimes mix up their medicine. So could it be an accidental ingestion of, for example, a sulfonylurea? Is the patient fasting or just very lean and doing a lot of exercise, or has anorexia nervosa? These are all causes of physiologic hypoglycemia. And then finally, we worry about not, and when I say ketotic, when people fast, the insulin level drops, the glucagon level rises, as I showed you on that slide, free fatty acids will be produced and keto acids will be produced, and that's what we're measuring in fasting, a physiologic fasting or starvation. We see ketosis. But non-ketotic hypoglycemia is what we worry about. This is where hypoglycemia is being caused at the insulin receptor. Just to go back to this slide, the idea is if you've got extra insulin, it shuts down that free fatty acid production here. When you have high glucagon and low insulin, you're going to have ketones. These free fatty acids are going to be converted into ketones. So if you have someone with low blood sugar and signs of insulin production, meaning there's no ketones around, it's non-ketotic, that's when you worry about something acting at the insulin receptor. And that can be an insulinoma. That can be a mismatch between insulin secretion and supply, like post-bariatric surgery or other GI surgery. It can be factitious, someone is taking insulin. And there can be antibodies that act at the insulin receptor. So anti-insulin antibodies, type B insulin resistance, you can get antibodies acting at that insulin receptor, causing quite severe hypoglycemia. I see a question in the chat. Let me just take a break. Oh, Melly put the slides in there. Thanks, Melly. Okay, great. Okay, so let me turn now with that background to talk about the most common scenario in which we see hypoglycemia, and that is in people with diabetes. So this is a case that I actually got very early on in my life as a doctor. I was like a fellow case. So this case actually dates from over 20 years ago, but it's a really instructive case. So I like to share it with people. So it's a 47-year-old man who had chronic pancreatitis and came to me as having type 2 diabetes for 9 or 10 years. He was treated with 3 orals, so rosiglitazone, metformin, and glyburide. His other medications were Prilosec, calcium, metformin, and glyburide. He was on pancreatic replacement enzymes and lisinopril. His A1C was 9.2, and he had a history of pancreatitis due to heavy alcohol use, was now abstinent, and he had chronic calcific pancreatitis. He actually had portal vein thrombosis with hypersplenism and thrombocytopenia and osteopenia. So really a pretty significant GI pancreatitis history. And he was married, worked for a grocery store chain, driving around from place to place, and smoked half a pack a day. So this is a case that we could spend a lot of time on, but just in general, what kind of diabetes does this guy have? You can put it in the chat or somebody can unmute and shout it out. Is this type 2 diabetes? Just in the interest of time, I'm going to say, although he's billed as type 2 diabetes, this is what's now referred to as type 3B diabetes, or what I like to call pancreatic diabetes instead of giving it a type. This is basically a man who has insulin deficiency and potentially other pancreatic hormone deficiency on the basis of his very severe chronic pancreatitis. So we can't really think about this as a type 2, even though he's being treated as type 2. He's insulin deficient, and despite the fact that he's on 3 orals, they're just not working. So so what are the next steps in this man? Notice he's not that overweight, although he does have an abdominal distribution. That my next steps were, let's start insulin. This is a man with pancreatic diabetes. These triple orals are not working. Time to start insulin. He said, I don't want insulin. I don't want insulin. So I said to myself, great, we're going to keep it simple. We're going to give you premixed insulin. So I started him on 75-25, 15 units in the morning and 30 units before dinner. And what happened? Well, it didn't really work. He was hyperglycemic a lot of the time. So I said, okay, let's increase that premixed insulin. And what happened? When I increased the premixed insulin, aiming to get his noon blood sugar into good range, what happened? And his dinner insulin, we started to get hypoglycemia when we were trying to cover his degree of a postprandial hyperglycemia. I'm sorry. So what I want to say here is that premixed insulin is not a good replacement for anyone who needs physiologic insulin replacement. And that would be anyone with type 1 diabetes or anyone with pancreatic diabetes, because these people are insulin deficient. If you try and use a premixed insulin, you really can't target the hyperglycemia without causing hypoglycemia. So lesson number 1 is don't use premixed insulin in people who are super insulin deficient unless you're willing to accept higher glucose targets, which may be appropriate for some. So, okay, I got the message. I said, boy, that was not, even though you said you only wanted 2 shots a day, we actually can't keep it that simple. Let's put you on basal bolus insulin. Oh, let's put you on basal bolus insulin. But before that, when evaluating a patient with any kind of hypoglycemia, again, you want to ask, what are your symptoms? What is the threshold at which these symptoms occur? He had that 58. Does he feel it? What's the treatment and response to the treatment? You want to counsel people to treat with 15 to 20 grams of a rapid-acting carb, retest and retreat. And then you want to look at the glucometer log, or now the CGM, and try and see what are his triggers of hypoglycemia. Was it overtreatment with insulin? In our case, it's obvious that we can't use premixed insulin in this insulin deficient man. But for some people, it can be overtreatment, or it can be exercise. It can be all sorts of things. You want to try and figure out what those triggers are and eliminate them. I do want to point out that although the conventional treatment to for hypoglycemia is to treat with 15 to 20 grams of rapid-acting carbs, in the modern era of hybrid closed-loop pumps, where the insulin delivery is decreasing, by the time hypoglycemia occurs, there's often very little insulin on board, and you often don't need that much carb to correct hypoglycemia in that sort of person if they haven't had a recent bolus. So you want to be careful about over-treating hypoglycemia in that setting, but in a person on subcutaneous insulin, we want to treat in the conventional way. Okay, so what happens when hypoglycemia is happening? And I kind of went through this before, but I kind of want to go through it again. The physiologic response to hypoglycemia, if you think about it, if I said to you, what's the first hormonal change in response to hypoglycemia? And just because we're on Zoom, it's hard to do this, is not glucagon. You know, I ask this to the fellows every year, they'll say glucagon. Glucagon is what happens when you're hypoglycemia. And that is true. But before glucagon falls, before glucagon rises, endogenous insulin level falls. So for those of us on the call who don't have diabetes, when we're getting hungry or fasting, our insulin level drops, just like I showed you in that first slide. And that normally starts to happen around a threshold of 80 milligrams per deciliter. And that insulin, falling insulin level in the beta cell signals to the next door alpha cell in a paracrine fashion, time to make some glucagon. And then the glucagon will rise at around 70. And this is like a beautiful homeostatic mechanism that happens where we don't even feel hypoglycemia because our insulin level falls, our glucagon level rises. It's very similar to driving, where you kind of take your foot off the gas as you're approaching the stop sign slowly, and then you apply your pressure on the brake. I'm teaching right now a teenager how to drive. Doesn't always go that smoothly, but for those of us who've been driving outside of Boston, we slow down, we take our foot off the gas, we slowly apply pressure to the brake. That's the way the insulin and glucagon system works, and we never experience symptoms of hypoglycemia as a result. But if those symptoms fail, if those hormonal responses fail us, the first counter-regulatory hormone that kicks in is glucagon. The next set of counter-regulatory hormones then comes out in full force. Epinephrine, cortisol, and growth hormone kick in around a level of 60 and say, hey, my glucagon is not working for some reason. We need to get mobilized glucose quickly. Let's, all systems go. Let's mobilize glucose from the liver. And that will lead to hepatic gluconeogenesis. And that works great. The problem is, if you knock out any of these systems, your response to hypoglycemia is severely impaired. So in our patient with pancreatic diabetes, what happens?
Pancreas.
What's that? I said chronic diabetes. In our patient with chronic pancreatitis, what happens? So thanks for, I couldn't 100% hear, but I think someone was just correcting my misspeaking. So, so basically, if we don't have a falling insulin level, we can't get we can't get a rise in glucagon level. And our patient with chronic pancreatitis who has no insulin and also has no glucagon because his pancreas has been chewed up by alcohol and chronic calcific pancreatitis is relying entirely on cortisol and epinephrine levels to mobilize a response to hypoglycemia. And that is what will finally cause him to have a rise in glucose level. And therefore his symptoms of hypoglycemia kind of kick in much later. And he will get some sympathoadrenal symptoms, but ends up with neuroglycopenic symptoms, and I'll show you why. So this is an experiment done by Phil Cryer, who actually just died this year, was an incredible scientist and physiologist of the mechanisms of hypoglycemia in humans, and basically showed hormonally how hypoglycemia unawareness occurs. So fundamentally, what he proved in this experiment and several others is that recurrent hypoglycemia basically blunts and then totally impairs the counter-regulatory response. And to demonstrate this, he took completely normal volunteers, people without diabetes, and he brought them into the lab. And you could see he dropped their glucose level from about 100 down to 50 by just giving them an insulin infusion. And what I'm about to show you is what happened on the first day that this happened. And then he brought them back on day 2, gave them the exact same insulin infusion, dropped their glucose again, and saw how they felt. So on the very first day, when they came in and they had normal glycemia, they had, low symptoms on day 1 and day 2 when they were euglycemic. They just kind of felt normal. Their epinephrine was very low. Pancreatic polypeptide, another counter-regulatory hormone, was low. Glucagon was very low because their blood sugar was normal. Why would these be high? But then what he did was, after exposing them, what you can see is on the first day, which is the black bars, when they started to get hypoglycemic, they got very symptomatic. That is the black bar of just like, wow, I feel shaky, sweaty, hungry, give me some glucose. Their epinephrine levels were sky high on day 1 in those black bars, similarly glucagon high. Day 2, after only one hypoglycemic episode, notice their symptoms were minimal, almost back to normal. So almost no symptoms on a second day of hypoglycemia. And their epinephrine rose, but not very much. Pancreatic polypeptide and glucagon, same thing. It rose not very much. Now, obviously, the reason this happens is that our system is designed to manage our energy stores in settings of chronic starvation. So if you're starving for days and days and days, you really don't want your counter-regulatory response firing in response to hypoglycemia. You need to down-regulate it to conserve energy and not be burning glucose every time the blood sugar drops. So this is a great response to starvation. It is a terrible response to insulin treatment and diabetes, because if you get one hypoglycemic episode, your response is going to be diminished. And if you get a second, a third, and a fourth, it really starts to blunt your hypoglycemic response, even in normals and for sure in people with diabetes. Now, we don't actually see this that much anymore, thank goodness, because with CGMs, we're really able to prevent a lot of hypoglycemia. But I think those of you who've been practicing, I'm sure have had many patients where, you'd see their glucometer, they would have hypoglycemia on a series of days. And then day 5, they would have a very serious hypoglycemic episode. And why was that? It's because of this recurrent hypoglycemia completely blunting their symptoms, leading to, really impaired awareness of hypoglycemia. Now, in the setting of diabetes, scrupulously avoiding hypoglycemia can restore this response, and you will see that in your patients. But anyway, so this is how it works. And in a guy like this with chronic pancreatitis, who has no insulin, has no glucagon, he really is relying totally on his epinephrine. So, once he starts to blunt, if he gets recurrent hypoglycemia, once he starts to blunt that response, and this was a pre-CGM patient, he really can experience quite severe hypoglycemia. Are there questions about this? Okay, so just to let you know what happened with this patient, he actually had progression of his chronic liver disease with chronic bile duct obstruction and cholestasis. He had a Klebsiella abscess. I mean, the guy was had a real liver mess. He developed cirrhosis, hypersplenism. On imaging, his pancreas was just like this atrophied, calcified kind of little thing. And he developed some diabetes complications, including neuropathy and non-proliferative diabetic retinopathy. I'm going to give you a little bit more history on the guy. So I told you he worked for a chain of stores. He works as a display manager for a chain of stores. He drives all day long. His eating pattern was he ate breakfast at 5 or 6 in the morning, snacked as he drove all morning, and ate a high-carb breakfast for lunch and dinner. At this point, I did have him on a physiologic insulin regimen. It was a little bit overly complex. I thought, oh, gee, it'd be great to cover his breakfast with regular. No, overly confusing. Don't do it. Just pick one insulin. He should have just been on Humalog. And the issues here in this man is that he's become chronically ill. He's even lost weight. He's become more cirrhotic. And his A1C is 6.6. He has no microalbuminuria. He's got signs of chronic cholestatic liver disease, and he has hypersplenism causing thrombocytopenia. So we've sort of hit on some of these, but just to get onto the other cases, I'll take you through this quickly. We've established that he has pancreatic diabetes. These people with pancreatic diabetes have very brittle diabetes because they have no insulin and they have no glucagon. So when they eat carbs, their blood sugar shoots up. But when they take insulin, because they have no glucagon and no insulin, their own insulin level doesn't drop to cause their own glucagon to rise. And then they have no glucagon. And so they really are relying on their epinephrine. And so they can have very, very brittle glycemia. And what that really means as a practical matter is you kind of often have to back off on glycemia in these people. Also, because of counter-regulatory hormone absence, they often don't have a lot of overnight counter-regulatory rise in their glucose. So they don't need that much Lantus at bedtime. You can often just give them a little bit of morning Lantus to get them through the day and just cover their carbs that they're eating every day. I want to point out that his laboratory tests are not accurate. He has hypersplenism and thrombocytopenia. This A1C is almost certainly an underestimate of his true mean glycemia based on the blood sugars he told us before. And then other questions you might want to ask this man who drives around from place to place. Concerns about his insulin regimen and his lifestyle in the pre-CGM era. So this is a man who drives for work. Anyone who drives for work, you really do need to counsel them about driving and insulin. And it's probably someone where you're not going to aim for tight glycemic control. Again, in the CGM automated insulin delivery era, this is not as much of a problem, but there are still people who don't have CGMs or don't have pumps. And you really don't want to aim for tight control in this guy. And you do also want to counsel him about his glycemic targets which indeed don't need to be very tight because he has established advanced cirrhosis, you're really not aiming to prevent microvascular complications decades in the future. You're aiming to maintain his health now. And then this is a guy where if he didn't have a CGM, you really want to counsel him to check his blood sugar before he drove, check his blood sugar every hour while he's driving, and make sure he eats when he takes insulin and really not correct insulin while driving to avoid any kinds of problems with driving. So I'm sharing this with you because indeed, 6 years after I saw him initially, after his liver disease had progressed, he did get into a car accident. And at the time of his car accident, his blood sugar was 26, he told me, and he had a fracture of his neck and his thumb. And he did report that he had not checked his blood sugar before driving and that he'd been sort of he'd had increased activity at his job. And that was to what he attributed his low blood sugar. I did go back in my notes. It turned out I actually had counseled him about diabetes and driving, but I was, very shaken up by this event. And what it turns out is that people with type 1 diabetes do have more frequent accidents than their spouses. People with type 2 diabetes tend to have about the same amount of car accidents as their spouses. And so this is obviously a real issue for people's safety, but also for people's kind of, ability to function in society. I think the most important thing for us to do as endocrinologists is to counsel our patients, make sure people are safe, not only with driving, but with any activity like climbing a ladder, riding a bike, anything where having a severe hypoglycemic event could lead to injury. And it is up to us to counsel them. 50% of patients with type 1 diabetes report never having discussed diabetes with their physician, driving, with their physicians. Sorry about that typo. Or they may not remember it, but it is an important thing to bring up even now. It's also important to note, though, that there are many things that can impair people when driving, not just diabetes. So it's not that people with diabetes should be singled out, but since these are the people we see, it's important to discuss. Okay, so he came to me, he said, gee, I had been more active and that's why I had that hypoglycemic event. Unfortunately, it turned out, as I learned when I was subsequently sent records, that, he came to me, he said, gee, I really want to go back to driving. Won't you sign these papers? I then got his records. He actually was a little bit confused from his liver. He was even so sick from his liver that he was being evaluated for a transplant. And the records showed me that at the time of his driving, he was actually intoxicated. And the other driver was killed. So it was truly a horrible event, really, really distressing. I was shocked. And the blood sugar of 26 was not really due to his activity and not just due to his insulin. It was due to the combination of alcohol and insulin. So let's talk about how alcohol works with insulin. So this is a study that was done in people who came in. Again, these are not people with diabetes. These are healthy volunteers, not on insulin. They just came in over an overnight fast, and they were given the equivalent of a martini, 4 martinis between 8 and 9 a.m. So they drank these 4 martini type drinks. And what you can see is in the person who just got water, no martini, as their fast persisted, their gluconeogenesis increased over the course of the day. But in the people who drank the martinis, they had impaired gluconeogenesis and therefore lower glucose on alcohol over the course of the morning. And this is all well and good in people who are not on insulin, but I think what you can readily appreciate is that if you're now on insulin with impaired gluconeogenesis, because the insulin is shutting off gluconeogenesis, and you're drinking alcohol, you're going to have a very severely impaired counterregulatory response to a falling blood sugar and indeed a risk of severe hypoglycemia. And so that was the contributor in this case to his episode. So very upsetting case. Just to point out, alcohol basically impairs gluconeogenesis, causing hypoglycemia, and of course increases lactate, leading to lactic acidosis. So I just want to say, obviously we all do have patients who drink with diabetes. What do I counsel my patients? I counsel them to eat with their alcohol. In other words, they shouldn't just be drinking and not eating. I counsel them to have no more than 2 drinks at a sitting, ideally less. And I counsel them to undertreat with insulin. So if you have type 1 diabetes and you're drinking, really that's not the time you want to be covering every carb. You really want to let the blood sugar run a little high, not just for the moment of the drink and the dinner, but even overnight, there's a risk of hypoglycemia into the next morning for the reasons I just showed you with the martini experiment. Gluconeogenesis will be impaired for quite a while. So, that's the advice I give to patients, because people are going to drink and you want them to do it safely. But of course, a lot of people with diabetes just decide not to drink, that it's not worth the risk. And this is why. So this was a very challenging case because he had essentially lied to me and he was facing imprisonment. He did have substance use disorder. He was a lovely person. He just really had this very serious addiction to alcohol and he actually had continued to drink despite progressive liver disease and really had not told any of his doctors of this. And in the end, he was imprisoned, incarcerated for this event. And he lasted, he basically in prison, what happened was he was actually put in a medical unit. I spoke to the nurse practitioners there frequently. They kept ramping up his Lantus to try to treat his hyperglycemia. But of course, you can't do that in pancreatic diabetes. It was causing very severe hypoglycemia. And although I sort of worked with them to try to improve the insulin regimen, they sort of never were able to manage him safely. And he developed pneumonia, sepsis, multi-organ failure, and actually died within 6 months of being incarcerated. So very, very sad and difficult situation. Let me just stop briefly and take a look and see if there are questions. Sorry, I'm getting all these like weird things about speaking language, but I'll just ignore that. So I want to share that case because it was kind of a case of hypoglycemia and diabetes that illustrates all of the very big risk factors: insulin deficiency, glucagon deficiency due to chronic pancreatitis, alcohol use, and the risks of driving as well. And I think there was one other in there. And then how to dose insulin appropriately. You really want to dose insulin physiologically to minimize the risk of hypoglycemia. So those are the main points I wanted to drive home from that case. Questions?
Diesel pickup truck was brought in as it would not start filling the dive.
President, New York State's biggest tree here,
Okay, I don't know if someone is trying to ask a question, but I'll just go back. Is someone trying to ask a question? Maybe put it in the chat and I'll call on you. Or okay, let's go on to the mini cases because we're shifting now from the very common scenario of hypoglycemia in diabetes related to insulin use and all those other factors to a bunch of mini cases, but let's keep the physiology in mind because that helps us figure these out. So mini case number 2, 23-year-old man with a body mass index of 18 kilograms per meter squared, very poor appetite, random blood glucose was 49. What are our questions for him?
Is he eating?
Is he eating? Thank you. No, he's not eating. He is training, he's running, he's not a big eater, he's not that interested in food, he just doesn't eat that much. What else?
Any medications?
No medications. How about Whipple's triad? Does he have symptoms? He has no symptoms. So this case could go 2 ways. It could be an asymptomatic random blood glucose with no symptoms, in which case it's just physiologic hypoglycemia. But sometimes you'll get a guy like this who's like athletic or training or, has anorexia nervosa, which can happen in men. I present this as a man to make it a little bit of a mystery case. And sometimes people will tell you, oh yeah, I feel fine. But then when I try and exercise or when I sprint or whatever, I feel woozy. And yes, they do feel woozy. And it's really because they essentially don't have a lot of stores, glycogen stores. They're not big eaters. And this is unfortunately physiologic hypoglycemia and maybe related to anorexia. It may just be related to a skinny guy who's not a big eater. But this is not, this guy does not have Whipple's triad. He doesn't have symptoms, neurocognitive symptoms. And this is not a person you need to work up for insulinoma. This is a person who needs to be educated about nutrition, eating, potentially evaluated for anorexia, if that's what the story suggests. But this guy will not meet the criteria of Whipple's triad, and he's not a person who you would embark on a workup. Let's see if there's a question. Oh, training for what? Sorry, he could be training for any sport. I actually get this case or question about twice a year. He's a runner, he's a wrestler, he's a biker, something like that. So an intense exerciser, you can see this in a very lean person. And so, so basically this is physiologic hypoglycemia. The fasting glucose can be quite low, as low as 30 milligrams per deciliter in healthy young women. And you absolutely have to have Whipple's triad before you start to evaluate this person for hypoglycemia. And I want to point out that if you were to fast him, which I would never recommend that you fast him, but if you were to fast him, you would find that he had no symptoms. His glucose would be low because he's fasting, normal fasting, your glucose will drop. His insulin level will also drop because he's fasting. His C-peptide will drop along with his, insulin, but not making any. Go ahead.
I
starvation and societal collapse. In fact, attacks just 9 of the nation's 55,000 electrical substations resulted in post-blackouts, plunging millions into darkness for up to 18 months.
Okay, I'm hearing a lot of feedback. I can't tell if you're asking a question, can you put it in the chat? Because whoever is, if it's a question that's being asked, there's a lot of feedback on your Zoom. I'm not sure why. I can't hear you clearly. You want to try one more time, or do you want to try putting it in the chat? I'm sorry, so much for the case settings. Okay, anyway, in the setting of starvation, his beta hydroxybutyrate will rise as a sign, his free fatty acids are being produced. He's making keto acids. This is ketotic. And if you were to try to give him glucagon, which I wouldn't recommend that you do, but you would see that his glucose doesn't increase after an injection of glucagon because, again, his hepatic stores are low. And if you were to screen him for sulfonylurea, he'd be negative. Okay, sounds like a TV. Please mute your mic. Yeah, if you're not speaking, mute your mic. I do encourage people, if you have a question, to unmute, but you have to have a clear audio to do it, or it doesn't work. Okay, so that was physiologic hypoglycemia. It could be pathologic if he had anorexia, but the hypoglycemia part is the normal response to low body weight and starving and fasting. Okay, mini case number 3. 37-year-old woman, status post Roux-en-Y gastric bypass, current BMI is 26 kilograms per meter squared. She is shaky, she is sweaty, she has palpitations, and so she has very clear adrenergic symptoms, but she also can actually progress to confusion, a neuroglycopenic symptom, particularly when she eats fast food, processed foods, or high-carb meals. So what is her diagnosis? And this is not a mystery.
Reactive hypoglycemia.
So yeah, so you could call it reactive hypoglycemia, but it's a special case of reactive hypoglycemia. What was that? Go ahead.
Dumping syndrome.
It could be dumping syndrome. And somebody put in their PBH, which is post-bariatric surgery hypoglycemia. So it absolutely could be dumping syndrome. And the concept of reactive hypoglycemia is you have a person who's eating a high carb or concentrated carb meal, processed foods, and for whatever reason, they put out more insulin than they need for the amount of carb that they've eaten. And that oversecretion of insulin kind of kicks in after they've digested the food, and boom, their blood sugar drops. And that is also what's happening in this scenario, but it's happening to an extreme degree because this person's GI tract has been completely rewired by bariatric surgery. So the carbs are hitting, so it could be dumping 100%. We don't know for sure. It could be this extreme form of reactive hypoglycemia that we see in post-bariatric hypoglycemia. And this, sadly, is not uncommon. So, whoops. So the rate of mild hypoglycemia can be pretty common. The rate of severe hypoglycemia, and I'm sorry, I didn't define hypoglycemia for you in this talk. I should probably do that. There's new criteria for hypoglycemia, but severe hypoglycemia is less than 55, sort of level 3, or requires assistance from another person to treat. And this actually can be very severe. And because there's so much more bariatric surgery going on, post-gastric bypass hypoglycemia is even more common than insulinoma. And so absolutely you will see this. I have someone in the chat saying, yes, you absolutely treat this with a change in diet. And getting rid of the high carb foods really can ameliorate this to a large degree, although not in everyone. But absolutely the first step is clean up the diet, get rid of the processed foods, complex carbs, just as someone has said in the chat. Can it be lean post-sleeve too? I'm going to say yes, and I'll explain why. So there are several described mechanisms here, which is the altered secretion of insulin and gut hormones with increased insulin sensitivity. Very rarely originally described was this phenomenon of this non-insulinoma pancreatitis, hypoglycemia syndrome of nocidioblastosis. And that is a kind of pathologic diagnosis where you see this branching of the beta cells. But you don't really necessarily need to invoke that. It's basically just an insulin mismatch. And a lot of people who've had bariatric surgery, even without gastric bypass, will have this. Why? They previously had obesity. They were insulin resistant. Maybe they have quite a bit of beta cell mass that was kind of present from their time of insulin resistance. Now they've lost a lot of weight. They're more insulin sensitive, and they're still eating the high carb meal. They're getting this exuberant insulin release, and you will see this kind of phenomenon. And the question is, how severe is it? If it's a person getting neuroglycopenic symptoms, very low blood sugars, that's a severe problem that needs to be treated not only with diet, but sometimes with medication. But the vast majority of people can see this with, can treat this with diet. Okay, I'm getting a question from Catherine Williams. We see this a lot in pregnant women who've had sleeves in our clinic. Can you explain the mechanism, please? So I think it's probably the same idea where they're getting a mismatch between insulin, and it ends up being, I'm sorry, but a bit of a hand waving explanation. If they're getting this syndrome, it's probably because for whatever reason, there is a mismatch in their insulin secretion, and maybe they have a bit of a history of insulin resistance. Maybe they're getting a little more insulin resistant with pregnancy, and their beta cells are hypertrophying to kind of manage the pregnancy. And so they're getting a big exuberant release of insulin in response to carbs, potentially more than they need. And then I have someone saying, yes, I've seen this post-Nissen, and that is absolutely my next slide. So the point I want to make is you can see this in a lot of GI surgery. I think you can invoke any time the GI has been rewired, consider that this could be a problem. So absolutely, it's been seen with the Nissen. And you can, and it could be dumping syndrome, but it actually can be this response to hypoglycemia. One of the things, of course, that the GLP-1 receptor agonists have taught us is that although we used to just think about insulin and glucagon, there's a whole panoply of gut hormones that get released in response to food in a very coordinated fashion that help us digest our food. One of them is GLP-1, one of them is GIP, which is the second receptor targeted interzepatide, but there's pancreatic polypeptide. There's like a whole slew of these gut peptides. And, you know, nature built us to have this all be released in a coordinated fashion. And when you start mucking with the plumbing down there, you know, these things can get mismatched and cause a problem. Okay, I'm getting a question about de novo postprandial hyperglycemia or hypoglycemia, really an entity. I think you mean hypoglycemia. And just stay tuned because we're coming to it. Okay, so how do you manage post-bypass hypoglycemia? Dietary modification, avoidance of high glycemic index carbs, eating complex carbs, sometimes cutting out carbs is the key to this. You can then do other things that will ameliorate the absorption of carbs. So acarbose works because it prevents a rapid absorption of carbs, which triggers the phenomenon. Verapamil probably doesn't work that well, but it's pretty harmless, so it's worth a try. Diazoxide will basically stop the beta cells from making insulin, so it will help, but you have a risk often in people with a history of insulin resistance of causing diabetes, so that's the problem. Somatostatin will shut down insulin, but it will also shut down glucagon, so again, it's kind of a big gun, but you might need it. The GLP-1, sorry, this is an old slide, liraglutide, but other GLP-1 receptor agonists, probably by helping restore the balance of insulin secretion in response to food, and potentially by helping people eat less in the way of concentrated carbs, can help the syndrome. And then I don't know if you guys heard about pasriatide on the Cushing's talk, but this is a serotonin receptor 5-HT blocker that is targeted for Cushing's. Or is it a somatostatin? I think it's somatostatin and a little bit of serotonin, but definitely a somatostatin blocker that actually causes a lot of hyperglycemia. So that's often a problem in Cushing's, but it can be used in this setting if needed. And if truly intractable problems, people may need to have surgery to deal with, reverse the bypass or deal with even a pancreatectomy or a partial pancreatectomy if it truly is severe hypoglycemia, but I think very rarely does it get to that stage. Okay, so that's post-bypass hypoglycemia. Okay, now let's talk about this person, which you guys are sort of already anticipating. This, I would say, is a common consult that you've all seen. 46-year-old woman comes to your office. She feels shaky after she eats, and she comes in for a hypoglycemia evaluation. You take your history. You get your history of Whipple's triad. She has, and you basically, I always ask people who come with hypoglycemia to keep a symptom diary. What do I mean by that? When do the symptoms occur? What are the triggers? Was it exercise? Was it fasting? Was it postprandial? If it was postprandial, what did you eat? If it was exercise, what type of exercise? Had you been fasting? I want a symptom diary, and I want to know the glucose at the level when the symptoms occurred and what were the symptoms. Were they adrenergic or were they neuroglycopenic? She has very clear story of postprandial shakiness, so an adrenergic symptom after eating with blood glucose levels of 55 to 65. Okay, so what are your thoughts about this patient? Anyone concerned? So for me, this is a hard consult. This is a person who makes me anxious because this person comes in anxious. And of course, you're like, oh my God, could this person have an insulinoma? Oh my God, could this person have a serious hypoglycemic disorder that will kill them if I don't solve this problem? And the question is how to evaluate this person. The first thing is you kind of have to already know what this person has in order to save yourself the whole yellow brick road of this evaluation. This is a person who is anxious themselves and makes you anxious. But this is the person who was asked about who you can have postprandial adrenergic symptoms with no documented low blood glucose. Okay, so one, we have to decide, do we care about this level of glucose? I think this level of glucose is not that severe and is not dangerous and is not enough to make me worried. If this person came with 50s or 40s, now we're talking. But 55 or 65 on a glucometer is not enough to make me worried. The other thing that's very reassuring about this person is that all the symptoms are adrenergic. And I told you that in severe hypoglycemia, people don't really get adrenergic symptoms. They've blunted their ability to have an adrenergic response. And what they get is somebody finding them confused. And this person never has confusion. She just has a little mild shakiness. And what does she do every time she feels shaky? She has a piece of candy, right? And so like she's eating to prevent the symptoms, and that would maybe even trigger more symptoms. So before I check even any glucose on this person, I don't even check a fasting glucose. You could ask her to check fasting, but the very first thing I will ask this person to do is clean up their diet and take a history. And if this person gives you a history of like, yeah, I have a jelly roll every morning or some other kind of pastry with my coffee, I say, why don't you try having an egg on whole grain toast and see what happens? And if they change their diet and that completely modifies this and they have no more symptoms, then you essentially have your answer. This is what we used to call reactive hypoglycemia. It's essentially the same phenomenon that we just described, where they have a little bit of an insulin overshoot to a high carb meal and they get very symptomatic from it. But the other thing you can do for this person is, okay, say you get the symptom and you don't eat your candy, what happens? Based on normal physiology, what should happen is her glucagon will kick in. So she feels a little shaky. She eats her candy right away and she thinks the candy's making her feel better. But if you just say, no, you know what? Let the symptom happen. Just sit there with it. Wait half an hour. What's going to happen? Her glucagon is going to eventually rise. Her liver is going to make glucose from gluconeogenesis, and she's going to be completely fine. She's not going to pass out, and the symptom will pass. And so sometimes you just sort of need to educate people. You're very sensitized to how your body is feeling. You maybe are getting a little bit of this reactive hypoglycemia problem. Sometimes it's in people who are a little bit insulin resistant, but yet making a lot of insulin to overcome their insulin resistance, and they get kind of an overly exuberant response. So it might be people with a family history of type 2 diabetes or insulin resistance, sometimes a little bit overweight. So this is a case where you really need to educate the person. Important when you're educating and kind of doing these dietary modifications is you never want to say 100% sure you know what it is, because you don't know what it is. You say this could be a lot of things, but what I think is most likely is this phenomenon that we absolutely see all the time. And some people are very sensitized to this. They feel terrible when this happens. We find that it can often be managed with dietary modification. We find that when you don't treat this with candy, the symptom will go away by itself. And although this is very bothersome and I can understand you feel terrible, this is not dangerous. This is not going to kill you. So I tell them that, but I say, I could be wrong. But because the evaluation of hypoglycemia is so challenging, we need to rule out this most common thing before I undertake the challenging evaluation. So do I do postprandial hyperglycemia? I mean, do I do a, so do you need to do a diagnostic CGM? You could do a diagnostic CGM, except you sort of already know what's going on. You could do it with the patient for education. So the patient would then see when they change their diet, how different their glucose profile is, both in terms of the postprandial hyperglycemia and the postprandial drop. So it can be educational, but this is a person in whom in general, I don't want to undertake any more evaluation. I really want to try and do the intervention. And if the intervention works, you're sort of done. And the reason I don't want to do any intervention is because if you do a mixed meal tolerance, you will absolutely provoke the symptoms. The person will feel terrible and you'll probably get a low glucose. But now this person who's already been anxious about hypoglycemia sees in the lab that they have a low glucose, and now they want you to work that up. But it doesn't really change your approach to this problem. And you're just sort of stuck explaining why you're not going to work up this low glucose. Does that make sense to people? There was a question in the chat, do you still use the terminology of reactive hypoglycemia? So unfortunately, they sort of did away with the phenomenon, the condition. There used to be a condition called reactive hypoglycemia. I personally feel like that was a useful thing to have, because when you have a patient who really has this kind of feeling of being sensitized to this, it's helpful to give it a label. And so what I often say to them is we used to call this reactive hypoglycemia. It's not really a disease, so nobody really considers it that anymore, but that's basically what this is. It sometimes can help people to give them a label and an understanding of what's going on, but it's not really, like if you look it up in a textbook, it's not going to be there in the same way. I'm going to say this is one of the hardest things as an endocrinologist because you get these referrals, the patient is anxious and you are anxious and you don't want to miss anything. But before going down the $1 million workup, start with the dietary intervention, trust your gut, take a good history. And if you feel like, okay, this is run of the mill, try to do the run of the mill things to handle the run of the mill. Okay, other questions about this case? All right. Okay. All right, let's keep going. Okay. Mini case number 4. All right. So this is a man, a 42-year-old man, new onset episodes of bizarre behavior. He wakes up in the morning and he's just acting odd. And his wife is like, what is wrong with you? But you know, everyone's just like, okay, this is him. He then gets sick with a viral gastroenteritis. He's nauseous, he's vomiting, and he just becomes frankly confused. And his family sends him into the emergency department where his finger stick blood glucose is 26. Okay, what is this? What's concerning about this story? Okay, real hypoglycemia. He's got a blood sugar of 26. It's occurring fasting. Somebody says, oh, AI. So yeah, it could be adrenal insufficiency, although very rarely do you see adrenal insufficiency in a healthy adult. You certainly could see it in the setting of gastroenteritis, and you definitely want to keep it on your differential diagnosis, 100%. But this is a guy who has neuroglycopenic symptoms. He never feels low. So this is real hypoglycemia. You have a real story of neuroglycopenic symptoms, totally blunted adrenergic response, and you have a real low blood sugar that is very low, 26. And so now you do start to worry, but this guy otherwise has nothing wrong with him. So now we start to go down our other path of like something else weird is wrong with him, just like I see people seeing in the chat. Hang on, let me get my chat up so I can see what you're saying. Okay. All right, so yeah, now we have to go down the whole differential of what could be causing this. So this is real hyperinsulinemic hypoglycemia, and it could be, I see people saying in the chat, insulin antibodies, it could be insulinoma, autoimmune, potentially malignancy if he's looks otherwise sick, adrenal insufficiency. This is where we really need to look for a problem. But the fundamental point here is that this guy has an inappropriate elevation of insulin in the setting of suppressed glucose. I didn't even complete the Whipple's triad for you, but when they gave this guy, you know, an amp of D50, he was like, oh, where am I? What's going on? And he was completely fine. So this is absolutely meets the criteria of Whipple's triad. In order for us to diagnose hyperinsulinemic hypoglycemia, the glucose has to be low. If you start to run these labs on someone with a glucose of 60, they're uninterpretable. Because as you can see from this nomogram here, when the glucose is 60, you can have insulin levels that are kind of as high as 3 or even maybe more. You know, if in an insulin resistant person, we sometimes, if you check a glucose in an insulin random, sometimes I'll get these consults like, his patient's insulin level is 27. Does he have an insulinoma? His glucose is 80. No, he's just really, really insulin resistant. And that's why his insulin level is high. So that can be normal. In order to diagnose an insulinoma, you need an inappropriately high insulin level with a very frankly low glucose, ideally less than 55. The other thing is your body only makes so much insulin. If you have insulin levels that are like off the charts, 100, 200, that's someone who's taking insulin. That's not an insulinoma, unless it's metastatic insulinoma, in which case it's not a diagnostic dilemma because that person is sick. So this guy actually did have an insulinoma. It's a very rare diagnosis, about 4 per million per year. Usually there is fasting hypoglycemia, but there can be postprandial hypoglycemia. And usually what's happening is these people are like subconsciously eating and they're kind of fine, but they get intermittent episodes of neuroglycopenia through an afternoon fast, through an overnight fast, when they become ill for another reason. But they have totally blunted their adrenergic response. You do not get a history of shakiness or sweatiness ever in insulinoma patients. It almost always is confusion. They've often had it for years, misdiagnosed as a seizure disorder before someone picks it up. And these people have impaired hepatic gluconeogenesis because they're making insulin that's shutting down their gluconeogenesis and shutting down their ketosis. Often people will have weight gain because they're subconsciously eating to treat the symptoms, and it's often misdiagnosed. Usually it's a single benign tumor, but sometimes they can be metastatic. We had a case last year of a metastatic insulinoma, which was very, very upsetting and hard to treat. And they can occur as part of a syndrome such as multiple endocrine neoplasia. Okay, so what's the diagnostic approach here? This is the person who you bring in for a fast. And you basically, your goal here is to provoke the hypoglycemia, usually in a 72-hour fast. almost always the person becomes hypoglycemic by 48 hours. There are papers that show that. But if you are worried about an insulinoma and you feel like you need to definitively rule it out for whatever reason, for your own sanity or the patient's, it has to be a 72-hour fast. But if the patient comes in and is confused in your office and is hypoglycemic, by all means, get the labs at the time that you're seeing them in the emergency department or the office so you don't have to do the fast. Clearly, you want to rule out adrenal insufficiency with a cord stim test, but if you just get a random cortisol when the patient's hypoglycemic and it's greater than 18, you're done. So you want to rule out all those things. Okay, so what happens during the fast? The fast is also very hard to do. It's hard to get the patient admitted. It's very hard to put a patient through a fast. It's very hard to put the nursing staff through a fast because everyone gets extremely stressed out. And these patients have been living with hypoglycemia for such a long time that they can sit there with a blood sugar of 55 being completely fine, but their blood sugar really has to go down to the point where they're kind of neuroglycopenic before you end the fast. And the reason is they need to have Whipple's triad, they need to be symptomatic, and their blood sugar needs to be really low. So you can look up fast protocols online, but basically what do? We bring people in, we put them on fluids, we let them walk around, we let them drink water, but that's it. And we just check their blood sugar every hour with the finger stick. We wait till it's low, ideally wait till there's symptoms, and then we check their glucose with their insulin, C-peptide, beta hydroxybutyrate, and a sulfonylurea and glycine screen. We don't usually do the glucagon. We don't usually do a glucagon injection, but classically that is described. In a normal fast, as I already showed you, you're going to have an increase in beta hydroxybutyrate, a decrease in endogenous insulin. Someone's taking insulin, which is about as common as an insulinoma, unfortunately, because insulinomas are so rare. People will have symptoms eventually. Their glucose will drop, their insulin will rise, but guess what? Their C-peptide won't rise because they've given themselves insulin. Their beta hydroxybutyrate will be suppressed because they're taking insulin. But if you give them glucagon, their liver is chock full of glucose. So it will release glucose and their glucose will rise after you give them that. And of course, they won't have sulfonylureas in their system. If they're taking a sulfonylurea, then you have an increase in endogenous C-peptide, just like you would see in an insulinoma, but you get a positive sulfonylurea screen, which is why it's so very important to do that test. And we do see this, unfortunately, over the years, we've seen it. But yeah, sorry, there's my little arrows. Okay, so how do you make the diagnosis of an insulinoma? 72-hour fast, ideally glucose less than 50 with symptoms, and then basically with an insulin greater than 3, a C-peptide greater than 0.6, elevated proinsulin, a suppressed beta hydroxybutyrate, almost all of the time, that can help you confirm you have inappropriate release of insulin, you've got an insulinoma, and then you have to go looking for the insulinoma. Clearly, you want to, in a perfect world, demonstrate this before going looking for a tumor because people can have all sorts of little things that are meaningless. So you do this first. Okay, questions. Do you routinely measure proinsulin in the 72-hour fast? What the proinsulin adds is sometimes the results are a little bit equivocal. So first of all, there can be proinsulinomas. There can be tumors making proinsulin. So that's one reason to measure it. But sometimes the results can be a little hard to interpret. And you can look at things like insulin to proinsulin ratio or insulin to C-peptide ratio. And I'm going to just refer you to the literature to look that up. So if you've gone to the trouble of bringing a patient in for a fast, it can be sort of a helpful additional parameter, but the vast majority of the time, you don't really need it. Okay, so take home points. Okay, you know what? I didn't actually talk about insulin antibodies, autoimmunity. We can talk about those in case discussions. If people have a case. If not, I can just share a case. But basically, because I wasn't sure how long this would take. But the real problem with hypoglycemia is that it's a major barrier to diabetes management. It's less of a barrier now because we have CGM. It's amazing how much less of a barrier it is, but it's still a problem. When people get hypoglycemic, you need to see how often is it occurring, what's the level at which symptoms are sensed. And I don't think I made this point clearly enough, but the reason you want to know the level at which symptoms are sensed is because if people say, oh yeah, I feel hypoglycemic at 80, great, that's fine. They can sense it, they can treat it. If people tell you, oh yeah, I feel hypoglycemic at 50, that's a person who's lost their counterregulatory response and is at risk of a very severe hypoglycemic reaction. And so you need to pull back on the insulin and let them ideally restore their sensation of hypoglycemia awareness. If people have hypoglycemia unawareness on the basis of neurologic damage, that's not going to come back. But this sympathoadrenal response is very fluid. And indeed, on the other end of the spectrum, I'm sure you guys have all had patients with diabetes who have uncontrolled diabetes who tell you they feel hypoglycemic at 120 or 140. They do, because they're so used to being high that their counter-regulatory response actually kicks in, you know, at a normal glucose level. So those are patients who need to be kind of counseled. But on the hypoglycemic end, you absolutely need to scrupulously avoid hypoglycemia to get that sympathoadrenal response back. And then anyone who has hypoglycemia unawareness or frequent hypoglycemia needs to have a relaxation of their glycemic targets and be counseled about driving and other high-risk behaviors. Hypoglycemia is super rare in the absence of diabetes. It's a very broad differential diagnosis. It's very challenging, and you have to be very thoughtful. Take a very careful history, get the history of Whipple's triad, figure out, is it sympathoadrenal or neuroglycopenic symptoms? Neuroglycopenic make you worry more. And do all of those things before you start to demonstrate. Try to do all of these evaluations, because the evaluations can be misleading if you don't actually have the clear story. Okay, so let me stop there and stop sharing. And I do have at least one case in the group for presentation, but before I go to that case, let me just see if any of the people on the call have questions or things they want to have clarified. Okay, how accurate is Dexcom monitoring in the diagnosis of hypoglycemia? Okay, so I just want to say this about Dexcom. This is more of a problem with the Libre. So, or probably not with the Libre 3, but with the older Libres, the original Libre, the original Freestyle Libre very clearly overcalled hypoglycemia. I think the newer ones are more accurate, and the new Dexcom is pretty accurate. So they're actually pretty accurate. The problem is people can sort of drift down to the normal range and kind of be hovering. If they're sort of hovering, you know, 65, whatever, that's not going to really get you your diagnosis. It really does need to go low. The thing about not fasting a person is the purpose of doing the fast is to get the diagnostic testing on them, not to demonstrate the hypoglycemia. You can usually demonstrate the hypoglycemia pretty easily. You can do it with a glucometer. You can do it with a CGM. You can do it with anything. Does that answer your question? Okay, in terms of the autoimmune workup, the autoimmune workup is very tough. Very, very rarely you will get antibodies stimulating the insulin receptor. People who, one scenario, actually, let me have the case touches on this. So let me have the person who's got the case present their case, and then I'll talk about it in the context of the case. So let me see who is, question, before we talk about the case, how do you differentiate dumping syndrome versus reactive hypoglycemia? Are they hypoglycemic? So if the person is not hypoglycemic, they have dumping syndrome. I mean, it's sort of very similar symptoms is how I would put it, but it's, I think, dietary modification for both scenarios. Okay, so who has got my case? I saw you on the call before, but where did you go? Are you still there?
Hello, Dr. Wexler. This is Vampirella.
Yes. Thank you. Okay, so do you want to quickly, so we have a complex case, but it's illustrative. Can you try and briefly present the case, and now maybe I'll draw the salient points, and we'll talk about the autoimmune workup.
I do have a presentation. Do you want me to go over that, or do you want me to just kind of...
How many slides have you got?
Let me take a look.
I probably should have looked at your slides beforehand. See if you can give us a succinct, why don't you show us your slides, but yeah, challenging case hypoglycemia, you've got a lot of slides. Can you just try and take us through the salient points? You can put it in screen share.
Are you able to see the screen right now? I share.
Yeah, put it in presentation mode and sort of take us through it quickly. And I'll maybe kind of move you along. I hope that's all right. If that's all right. If you go down to the bottom of your screen and just make sure you're in presentation mode. Oh, I don't know. It's different on Google.
Yeah, it's
all right. Okay, go ahead.
Perfect.
So take us through quickly if you can.
Absolutely. So I had a patient, 55-year-old. She was referred to us from an outside facility because of abdominal pain and some drainage beneath her umbilicus of 1 week duration. At the time of presentation, she was tachycardic, tachypneic, had borderline low blood pressure. Her past medical history was significant for connective tissue disease overlap, SLE, and systemic sclerosis, for which she was on chronic steroids. And she also had a history of GI surgery in the form of small bowel obstruction, for which she underwent exploratory laparotomy and iatrogenic bladder injury as a complication. She also did have a chronic history of protein calorie malnutrition, cognitive impairment, making it difficult for her to voice symptoms. And I would say suspected adrenal insufficiency because she was never formally diagnosed. As per what I got from her endocrinologist, she was only empirically continued on steroids. On labs, her serum glucose at the time of presentation was 53. She had leukocytosis, thyroid function, the TSH was normal. There was evidence of osteomyelitis, possibly the source of sepsis. She was admitted and started on antibiotics. That night, a rapid was called on her because of severe hypoglycemia, glucose reading of 33. However, this was on a POC, and it failed to improve with dextrose boluses. Patient was placed on a drip. And the hypoglycemia was attributed to adrenal crisis in the setting of an active infection, that's sepsis, and the patient was started on stress dose steroids. During the hospital course, she had a fluctuating PO intake, which was complicating things. Her hypoglycemia was episodic, very random, but predominantly fasting. And she had normal renal function and normal liver function, except for serum albumin, which was low because of her malnutrition. So this was—
Take us through her meds. Let's just if you could highlight her meds very briefly.
Sure. So pertinent medications, she was on hydroxychloroquine for her connective tissue disease, which was discontinued at the time of presentation because of sepsis. She was on levothyroxine, and hydrocortisone was 25 BID. Again, the problem was she was lost to follow-up from her endocrinologist since, end, so we don't know. And she was also on phenobarbital for a history of seizure disorder.
Okay, great.
I just outlined the graph of her serum glucose levels and the way we managed her steroids. So initially she was on stress dose steroids, and we can see that her serum glucose was improving, but she would still have these episodes of low blood sugars, and sometimes it would drop very low. This was at a point where we tried to wean her down to PO hydrocortisone back to her home dose, and we continued on a higher oral dose for a while in an attempt to relieve her hypoglycemia. But then at one point, we had to switch her back to stress dose steroids because it wasn't just getting better with a higher than normal PO dosing of her hydrocortisone. At this point, we decided that we should probably look for alternate etiologies, considering that it's probably just not her adrenal insufficiency. We did conduct a 72-hour supervised fast. The fast started around 7 p.m. and by the next day morning, 4:20, her serum glucose was 32. She didn't voice any symptoms, but objectively, she was lethargic, she was confused. And these were her labs, exactly taken at the same time as the serum glucose. Her insulin level was 9, proinsulin was 5.9, C-peptide was really high. Her hypoglycemia screen was negative, insulin autoantibodies were negative, and her beta-hydroxybutyrate was suppressed. Based on this, we suspected insulin-mediated hypoglycemia. We did a CAT scan, which showed no masses to correspond to a clinically suspected insulinoma. It also did show that her liver and her pancreas didn't have any other masses there. Then we went ahead and did an endoscopic ultrasound, which also showed no evidence of a pancreatic mass. We then did an intraarterial calcium-stimulated hepatic venous sampling. And again, I'm not a super expert on this, but it does seem like there are high insulin levels in multiple territories. We are still waiting for interpretation of this test.
You didn't necessarily feel like that localized. Your purpose in doing that test was to see, not being able to identify a visible tumor, could you localize the source of the tumor? And I'm just not clear whether this test helped you do that or not. Do you have a feel for that yet or not quite yet?
No, so it definitely
it's sort of generally high, right? So if they're all high, it didn't really help you localize. Is that how you guys are interpreting it?
Correct. But having said that, it's also not normal because we would not expect the insulin levels to be high, but yes, it did not localize. So I spoke to her endocrinologist actually today, just to find out if her hypoglycemia is just happening now or has it been going on for a while. And she did give me a lot of informative stuff. So her hypoglycemia was first noted when she was hospitalized for the small bowel obstruction in 2020. That was the first time they noted it. And after that, she had subsequent episodes both at home as well as in the hospital. And despite increasing her steroid doses to supraphysiological doses, her hypoglycemia didn't get better. And prior to the 2020 episode, she apparently had a 100-pound weight loss that was unintentional over a span of 2 years. She also confirmed that there was no prior testing for adrenal insufficiency. She was just kind of continued on steroids on presumption. And the endocrinologist who was seeing her did a 72-hour fast and mixed meal testing, the 72-hour fast just showed that she had discrepancies on POC glucose and Dexcom readings. For some reason, I understand that they didn't do blood glucose readings. They were monitoring glucose on Dexcom during the fast. And there was a clear discrepancy between both, making POC glucose readings unreliable in her because of her sclerodactyly. And the mixed meal testing was inconclusive. So the endocrinologist started her on an empiric trial of diazoxide, and she reports that her CGM glucose readings improved to the 90s, and then the patient was lost to follow-up until we saw her in the hospital now.
Okay.
So yeah,
go ahead.
we are lost.
Differential diagnosis. Go ahead.
So our differential diagnosis, of course, this is a really sick patient with multiple comorbidities in her, but just because her hypoglycemia has been going on even in her otherwise stable condition, and there is evidence of insulin-mediated hypoglycemia, we've kind of narrowed it down to either insulin receptor mediated, in this case, stimulating antibodies, or a non-insulinoma pancreatogenous hypoglycemia based on the calcium-stimulated venous sampling results.
Great. Okay. Thank you for this case. So this is like quite a case. And I think, I think when you think about the category of sick patient versus well patient, this is clearly a sick patient who's got a lot of things going on. And actually the history of obesity with weight loss and current malnutrition and GI surgery does feel like it has the feel of this was a person who maybe was a little insulin resistant, has got some beta cell hypertrophy, is now underweight, malnourished, and seems to be making more insulin than she should. It doesn't seem like she should be this hypoglycemic just from that alone, however, in my view. If she did not have adrenal insufficiency before, she's now been on chronic steroids and probably has adrenal insufficiency now. And with the phenobarbital, she's metabolizing the hydrocortisone. So she probably does need a higher than usual replacement dose to maintain an adrenal sufficient state. I'm not sure if you felt convinced that the high dose steroids were enough to help her though, because it seems like she had hypoglycemia at the time of, even when she was on high dose steroids, she had hypoglycemia at times. Is that correct?
Correct.
Yeah. So the question is, what more to do? I do want to take a minute, before we got this history of, the weight loss, because, Pranathi had written to me earlier in the week, just happened to write to me about this case. And I said, well, this would be a great case for the court. So thank you for preparing this and sharing it with all of us. Because of her history of lupus, it is in the setting of lupus where we do see a lot of times this autoimmune stimulation of the insulin receptor, where what's classically described as actually type B insulin resistance, where there are antibodies acting at the insulin receptor, blocking the insulin receptor, leading to basically intractable hyperglycemia that cannot be overcome. But those antibodies can also be stimulating antibodies, which cause hypoglycemia. And so you can sometimes see that in insulin, and the test there is for, not blocking out what the test is, but I wrote it to Pranathi the other day. It's a certain kind of antibody, an insulin receptor stimulating antibody test that's sort of a rare test, but you can do that. But I don't think you would want to send that out in this case because it does not seem like that's what's going on here. It seems sort of more like the perfect storm type of situation, with multiple medical things conspiring, including her nutritional status. So I would have to say my approach would be to do a formal court stim test and actually document that she has adrenal insufficiency to try to get her on an adequate dose of replacement steroids, but it doesn't seem like that's going to be enough to take care of her nutrition, but it doesn't seem like that's going to be enough. And then potentially at that point, see where she is and add diazoxide like you did there if needed. That would be, I think, where I would go with this before undertaking further workup, but I'd like to hear what others think. Colette is raising her hand. Go ahead, Colette. And actually, Pranathi, thank you for that awesome presentation. Could you stop sharing this so people can unmute themselves and raise questions?
Sure.
Colette.
Thank you. Sorry, I was thinking if it's just stimulation of the insulin receptor, should the insulin levels be high? Because
no, not necessarily.
Insulin levels were high, so yeah. I wouldn't have thought that was plausible in this case.
Is not plausible in this case. Say that again.
Yes, that's what I'm saying. I shouldn't have thought it was plausible. I don't think it's plausible in this case because it's stimulation of the insulin receptor. The levels shouldn't be high. So it still has to be something else causing a high insulin.
I agree. I think it's her own endogenous. I mean, as Pranathi sort of postulated that, this history of weight loss, increased beta cell mass at some point, rewiring of the stomach, leading to, I mean, it's almost like a post-bariatric kind of situation where she has, excess insulin secretion. I think what's interesting about it is she does have it fasting as well. So the fasting part I would attribute to the adrenal insufficiency. The postprandial part I would attribute to the kind of similar to the post-bariatric surgery where she's had the GI surgery and a history of weight loss with potentially prior insulin resistance and a high beta cell mass. But yes, at this point, I would not check insulin receptor antibodies for exactly the reasons you say. Other questions, thoughts? Other little mini cases or questions that things people have encountered in practice that they want to bring up? Or Pranathi, do you have anything else you want to say or ask at this point? I don't mean to.
No, Dr. Wexler, thank you.
Okay, thanks. Thanks for presenting the case, and thank you for the extra legwork. I think with the extra history, it becomes clearer, right?
Yes.
Okay, so for the if you're worried about a type B insulin resistance syndrome or an insulin receptor antibody, hang on, I forgot the name of the antibody. Pranathi, let's see, what is the name of it? I think it's an anti, what did I tell you? I'm looking for the exact name. Oh, the other things. It's basically, you'd have to look it up but I think it's basically an insulin receptor stimulating antibody is I think what it's called, but I have to find it. Find the exact test. The other thing I want to say is if you are looking for an occult insulinoma, because when Pranathi first emailed me about this case and it looked like it could be an occult insulinoma, the additional test you could do is a dotatate PET scan. So the dotatate is it goes to neuroendocrine tumors and the PET scan helps co-localize it. I will tell you though, even though they have me up here talking about hypoglycemia and people sometimes write to me from around the country with questions about hypoglycemia, whenever I get into these rare things, whether it be IGF-2 or what have you, I do always go back to the literature and look it up again because there's often something new and B, they are so rare that it's important to do that. The reason I want to make the point about not checking tests if you don't have a diagnosis is that I had a case referred to me about a year ago of someone who fit the profile of the mini case I gave you with a kind of a mild reactive hypoglycemia. But someone had done the big workup on her and checked an IGF-2 and her IGF-2 level was elevated. And this was like a totally healthy person. There was nothing wrong with her. Usually when you have an IGF-2 secreting tumor, it's an obvious tumor and the person is sick. But she just had a mildly elevated IGF-2. And she actually, because these assays are so hard to do and so rare, the mildly elevated IGF-2 was actually a false positive. And I won't kind of take you through the whole thing, but basically her history was not suggestive of a real problem. If I hadn't gotten any of those labs, I wouldn't have checked them. And I said, look, I don't actually think that you have an IGF-2 problem. I think this is really just the common scenario that we see all the time. Can you try modifying your diet? Can you do these things? Can you, instead of eating the candy, just let the symptoms pass and see what happens? Because you're not actually going to develop severe hypoglycemia. And indeed, when she did all those things, she was like completely fine. And she thought I was, like this, how did I figure that out? But I was like really nervous because she had this elevated IGF-2, right? So I, of course, repeated the IGF-2 and she had some the IGF-2 is bound to IGF binding proteins. She had an elevated IGF-2 binding protein. And so likely the reason that her IGF-2 was elevated was that her binding protein was elevated. And I said, look, I don't think this is an IGF-2 problem. I think you just have a polymorphism where you have a high IGF-2 binding protein. And therefore we saw this high IGF-2 level. I think you're fine. I can't be sure that you're fine. But if you continue to feel well, that's great. Come back and see me in a year. Because of course, if you're not sure, best thing to do is bring people back and see what happens. She came back a year later. She'd actually lost a ton of weight because instead of eating to treat the hypoglycemia, she wasn't eating to treat the hypoglycemia and she basically lost 15 pounds. And actually by losing the 15 pounds, she was having less of an insulin overshoot phenomenon even when she did eat high carb foods. And she actually felt and was much better. I then rechecked her IGF-2 because at this point, I just felt like, okay, I know it's not IGF-2, but I just, oh no, this is what it was. I hadn't even wanted to recheck an IGF-2, but I had put the order in the prior year and it had never been drawn. So when she got her routine labs drawn, her IGF-2 was rechecked and lo and behold, it came back completely normal. So she had never had an IGF-2 problem, really. But this kind of extra workup of these rare tests that have assays that can be inaccurate sort of led us down a path that we would have been better off never going down, which is why the history and kind of feeling like you know where you want to go before you do the testing is very important. Okay, so that's all I have to say, I think, unless there's other questions. Tomorrow is Diabetes Day. Be excited. We have great speakers lined up. David Nathan is going to kick things off in the morning, and I'll join you mid-morning and then be with you the rest of the day for a great series of diabetes talks. Yeah, so somebody's putting there's lots of case reports in the literature. I should mention that the case that I presented of the insulinoma was the New England Journal CPC. So if you want the details on that case, you can look it up there. And yeah, anytime you want to know about these weird hypoglycemia things, before you do anything, it's really time to look it up and just think it through before you do any testing. Thanks very much. Oh, okay. So Annapurna is talking about an insulin receptor antibody. Yes, if you do have an autoimmune hypoglycemia, then yes, you have to treat as an autoimmune disease, and treating with rituximab works. Knocking down the antibody syndrome works. And it is more common usually in people with lupus, usually kind of bad lupus. Okay. All right. Thanks, everyone. A long calcium day followed by a long afternoon case. Have a great evening, and we'll see you tomorrow morning at Diabetes Day. Thanks a lot. Take care. Bye-bye.